All right, so we're going to welcome our third podium presentation. That's much slower than it was. And given that our buildings and grounds at Eastern State Hospital are tobacco-free, it is more important to have tobacco treatment readily available. Yazan Al-Mrayat, along with Mandy, thank you. Strong, Kaitlyn French, and Okoli will discuss tobacco treatment within the inpatient and outpatient settings, and then we will have time for a break. All right, I invite them to the podium. Do you want to re-mic each other or speak from the podium?
I would not try this.
Perfect. And then if you don't mind, just pass it down the line.
Hello, good evening, everybody. My name is Yazan Al-Mrayat. I'm a PhD student at the University of Kentucky College of Nursing. Dr. Okoli's team at the Eastern State Hospital. I'm going to present to you a 10-minute presentation. It's clear? All right. Thank you. I'm going to introduce a 10-minute presentation about how to estimate nicotine consumption among patients who are poly tobacco users. All right. Even though it's a 10-minute presentation, I was hoping by the end of these 10 minutes that you will be able to define the meaning of tobacco, what is meant by cigarette equivalents, and to describe how we calculated these cigarette equivalents, and to assess and to apply the table that we have come up with on how to estimate cigarette equivalents for those who come with varying types of tobacco use, and to realize the effectiveness of such an approach in estimating the consumption of estimating the amount of nicotine consumptions in these patients. Well, in 2018, the CDC has estimated that 14% of the total adult U.S. population are still current smokers, which is like the lowest ever recorded prevalence of cigarette smoking among the U.S. adults. However, when we look at this phenomenon differently in terms of tobacco use, we find that 19% of the adult U.S. populations are current tobacco users. Moreover, when a survey was conducted and asked U.S. adults on the use of various types of tobacco use, they found that 14% of the total population answered yes to using e-cigarettes, hookahs, cigars, and/or smokeless tobacco during the past month. If we took a more international perspective on this phenomenon, we find that in a study, in an international study supported by the WHO, they found that among 44 countries between 2008 and 2012, that poly tobacco use rate was as high as 12%. Moreover, when they took like a more focused look on 28 countries, they found that 20% of those who were cigarette smokers were at least have at least used one more type of tobacco product. So who has the highest risk of this phenomenon of using more than one form of tobacco? We find out males compared to females are more susceptible. Younger adults less than 65 years of age, American Indians, Alaska Natives, whites, blacks, or biracials compared to Hispanics or non-Hispanic Asians. Adults who live in the southern part of the US, or the Midwest regions, compared to those who live in the West or Northeast regions of the United States. Those who were financially disadvantaged, earning less than $35,000 a year, and those who have a different sexual orientation, In addition to those who have disability or limitation, and they mean physical at this one, in addition to those who have a serious psychological distress, which includes our population of interest. If we take a closer look at the number of users of these tobacco products, we find that the number of patients, I'm sorry, I have to go back. Oh, the blue green. Okay, we find that those who use cigars and little cigarettes, the number of this population reaches up to 9 million users. For those who use snuff or pouch snuffs, the number is around 1.3 million users. For the smokeless tobacco, which includes, is usually expressed by users as dip, spit, or chew tobacco, we find that the number of users reaches up to 5.1 million users. In terms of the pipe and hookah, we find that 2.6 million users in the United States, and not unsurprisingly, we find that e-cigarette users reach up to 7 million users in the United States alone. And the oldest number in this slide is 2 years ago. So these numbers are quite recent. So how can we assess the amount of nicotine consumed by patients who use varying types or forms of tobacco? We conducted a literature review, and we looked specifically for the nicotine content for each tobacco product, which is the number of milligrams per 1 gram of that tobacco product. The nicotine yield. A nicotine yield is a method of calculating the amount of nicotine reaching bloodstream. However, they're using this approach as a proxy, but rather than an exact amount of tobacco reaching the bloodstream. We also looked for the cotinine level, which is the metabolite of the cotinine of the nicotine we find in the blood, and most precisely the plasma nicotine concentration. And we looked for anything that we can find for any of these products. And luckily, all of these values can be found for cigarettes: the nicotine content, nicotine yield, the cotinine level, and the plasma nicotine concentration. Where we could find these values for cigarettes. So we used these values as our gold standards to compare these values of each tobacco form to the values found in one cigarette. So we come up with a table. If you can see, in the first row, we can tell that one cigarette equals one in terms of the number of cigarette equivalents. And for one cigar, we found that the nicotine content per one cigar, and this is an average, because there are varying weights and varying brands that can be found on the market. We found that on average that one cigar is equivalent to smoking 1 cigarette. For a 1 cigarillo or little cigar, we found that it was equivalent to 3/4 of a cigarette. And for 1 can of snus, of a loose snus, we found that it was equivalent to 32 cigarettes. 1 can of pouch snus was equivalent to 27 cigarettes. And 1 can of loose smokeless tobacco was equivalent to smoking 124 cigarettes. And again, this was based on the weight of the can, which was average to 34 grams per can. Yeah, these numbers are surprising. And we found that if you take a look at the 1 can of smokeless tobacco, we found that the nicotine content is 421 milligrams per can compared to 18.5 milligrams found in 1 cigarette. And whenever possible, we use the most rigorous measure to compare to the number of cigarettes. For instance, for the smokeless tobacco, we could find the number of free or unprotonated nicotine. So we compared that one, which is the number of nicotine that is supposed to reach the plasma. So we compared that one to the one found in 1 cigarette. Moreover, one session of hookah was found to be equivalent to smoking 20 cigarettes. One bowl of pipe tobacco was found equivalent to smoking 6 cigarettes. And ad-lib using of e-cigarette, the new generation e-cigarette, was equivalent to smoking 1/3 of a cigarette. So giving this amount of nicotine consumed by an ad-lib use of e-cigarette was equivalent to this amount of nicotine found in one cigarette. We find it that unsurprisingly that to find other countries in the world adopting this approach as a tobacco cessation measure. So if we need to rehearse a little bit. So imagine that you're a tobacco treatment specialist, and a patient comes to you at the clinic saying that he smokes 10 cigarettes per day, in addition to 2 cigarillos. How many number of cigarettes would you like to estimate in terms of the amount of nicotine consumed for that patient? So 1 cigarette equals to 1 cigarette equivalent. So half a pack equals 10 cigarettes. So that's 10 for the cigarettes. And if he smokes 2 cigarillos, that would be like 1.5 more cigarettes. That would be like 2, yes. So it's 11.5 cigarettes per day. This is crucial for tobacco treatment specialists if they need to calculate the amount of nicotine replacement therapy for these patients. And this is what we have applied in Dr. Okoli's project, is to calculate the amount of nicotine tobacco treatment based on the amount, the estimated amount of that each patient may have consumed per 1 day. Moreover, there's this way is like an objective way of estimating nicotine consumption, especially for researchers. And I'm happy to entertain any questions. Thank you so much. I have one.
Do you think we can get the admission doctors to order nicotine replacement? That's okay. Do you think we can get the admission doctors to order nicotine replacement based on how much they're actually taking in? Repeat the question for those on the Do you think we can get the admission doctors to order the proper amount of nicotine replacement based on how much they're consuming? Because
this has not been done before in the literature, and this is an unpublished work so far. But we're hoping for clinicians to adapt this approach. And this is basically our question for Dr. Okoli, because he's the chief of the department. So yes, hopefully, we're hoping so. Thank you so much.
Currently, I am working at Eastern State Hospital as a mental health care associate. That's for those of you all who are not familiar with that position. I'm basically a nurse aide, which I am greatly privileged to be doing that right now. And one of my favorite things that I get to do on a day-to-day basis, or 3 days a week, is get to know my patients and get to know their stories. I get to hear about their day-to-day lives, and they may be 50 years older than me, they might be my age, which is so awesome. And one of my favorite patients that I've ever had, she was actually my age, right around my age, I'm 22 years old. She expressed to me how she had tried to quit using tobacco about 10 times. And when I heard her say that, I just thought, oh my goodness, we have to do something to help her. I really want to make a difference in this person's life, and I really think that we can target information towards her and see how we can help her. So part of my motivation in working on Dr. Okoli's team is to help patients like her who really want to quit but just haven't been able to do so successfully yet. Okay, so the background. We know that people living with mental illnesses experience greater rates of tobacco use and lower rates of tobacco cessation. We think this might be due to the fact that they lack relevant health care information for tobacco cessation, that accounts for their lower health literacy rates. And we want to tailor information towards mental health care providers so that it is specific to their practice and the patient population that they're treating. And by doing so, we think that it will engage their patients at a greater level and hopefully allow the patients to adhere to the tobacco cessation programs. So our objectives in this project were to develop and evaluate tailored tobacco cessation pamphlets, which you can see on the screens below, and I'll have them blown up and later on in the presentation so you can see them in greater detail. We want to encourage engagement in tobacco treatment upon discharge. So theoretically, these pamphlets would be given at discharge when you're going through the paperwork, and it's just a way to help the patients begin that first step in tobacco treatment. Okay, so these are our target participants. So we are hoping to have 16 inpatients from Eastern State Hospital. We're going to go through the 4 major disorders. So 4 patients with psychotic disorders, schizophrenia, schizoaffective, etc. 4 patients with depressive disorders, 4 patients with anxiety disorders, and 4 patients with substance use disorders. So we're going to use, you'll see the reason why we chose 16 is it's an even number, and we're hoping to have 8 females and 8 males. And then we're also going to include the providers because it's important that the providers have their say in how they think that these can be useful or what we could change to make them better for you all to use. So we're going to have 4 advanced practice providers, whether that be physicians, APRNs, physician assistants. We're going to have 4 social workers, hopefully 4 psychologists, and 4 registered nurses. So if anyone wants to participate. So this is our intervention description. So on your all's right-hand sides, respectively, you'll see the actual thing that I'm using during the interviews. So it's it's a rating scale, and on the infographics or the pamphlets themselves, we're rating them based off of the categories. So the first section, second, third, etc. And then we're also talking about the color, whether they like if they're gender specific or not, and just rating those on a level of 0 to 4 in 3 different categories. So desirability, acceptability, and applicability. And we are defining those terms, which I think is important for our patients, just because those terms, might not mean might not mean the same things to everyone. So I'm making sure that I define those terms with each question. And a 0, if you rated a 0, it would be do not include this, whatever that might be, whatever category. And then a 4 is definitely include it, we need it. So I'm using a mixed method approach, semi-structured face-to-face interviews. They're lasting about 30 minutes to an hour, depending on the patient, depending on redirection, things like that. And the sampling of patients are people that have used tobacco within the last 30 days. So that's how we're defining current tobacco users. So, okay, these first are the pamphlets for women. So I'm going to point out a couple different differences between the women and the men. But first, I just want you to realize that we have 2 for each. So we have what we're calling a cartoon version, which is on your left, yes, and then what we call the real life version. So they don't really have any difference besides just the graphic images. And we're wanting to see which one can be more relatable to patients. Some patients might relate more to the cartoon, some might like the real one. So we just want to see. And then we're using colors that we think are geared toward more of that gender. So then pamphlets for men. So these are the male pamphlets. And rather than in the female patient one, we talked about pregnancy and how that relates to women. So for men, we talked about for your family, which is in the top right-hand corner of the pamphlets, just to give that extra gender-specific target and allow for more of a relation to their duties, I guess. Okay, so our results. I've completed 4 interviews. Interestingly enough, all of them have been with females, so I'm waiting to get some male input on these. These are the disorders that they've had, so schizoaffective, anxiety, major depressive, and bipolar disorder. three of the patients actually liked the cartoon version more than the real version, which I was a little bit surprised about. And 3 did not mind whether the pamphlets were gender specific or not. But I will say a little caveat that one of the patients of those 3 said that purple was her favorite color, and that's why she didn't think that anyone would like any other color. She thought that purple would be perfect for everyone. So you have to consider our patient population sometimes. Okay, so furthermore, medications in the center of the pamphlet. This was something that I never, in helping develop these, would ever think about. I'll go back to the pamphlets in a second so you can see what I'm talking about. But a couple of the patients mentioned that in the row that talks about healthcare providers, and then it mentions counseling and it mentions medications, medications was placed in the center. And we know, based on research, that women actually tend to gear towards more like counseling, and that helps them with tobacco treatment more, or tobacco cessation treatment more than medications. But males tend to lean towards more medication treatment for tobacco cessation. So a couple of the patients were actually really bothered by the fact that the medications were pictured in the center, which is not something that I would have ever thought about. So we're thinking that as the interviews continue, that we'll possibly change, just flip-flop counseling and medications. So medications isn't in the center, and then that doesn't even give that portrayal. I'm gonna go back just for a second so you can see, if it'll let me. Okay, so you can see on the real version specifically, that was the one that they were most bothered by. And the medications are both red, which we know can be a triggering color, which I think is kind of interesting. And just the fact that the medications are in the center has bothered some of the patients. Okay, and then secondly, having information on community-based tobacco treatment resources the patients thought were really important. So on the bottom row of our pamphlets, we talk about the quit line, we talk about some other resources that they can use, and one of the patients expressed how the quit line helped her tremendously, and she actually completed their, I think it's a 6-week program, and she appreciated just having a little bit of a reminder. And then my favorite thing that I've gotten out of, my favorite suggestion out of all my interviews is the idea of making these into fridge magnets. I think it would be a great daily reminder, you know, everyone goes to their fridge and gets something to drink, or whatever, some food, and they get to see our pamphlets on the fridge. You know, just a little mini version just to remind them, hey, I can keep going, I can keep participating in my treatment. And then participants placed emphasis on healthcare providers, meeting them where they are in their tobacco cessation journey. So most likely, all of us at some point in our lives have heard the trans theoretical model, you know, stages of change. Well, I think it's important to note that these patients realize they might not have ever heard that term, they might not know, but they realize, hey, I'm not ready yet, or I'm thinking about it, but I don't know how. So as healthcare providers, it's important that you recognize that these patients might want to change, but they're not ready. They might be preparing, but they don't know how. So just take that into consideration when you're treating people for tobacco cessation. Okay, so the pamphlets seem to be an appealing method of supporting engagement in tobacco treatment. It's, like I said, a daily reminder if they can keep this with them. And then we think that involving both patients and providers in the development of pamphlets can ensure their acceptability by the target audience. So we think that by utilizing both providers and patients, that it'll make the greatest and biggest outcome and successful outcomes. And our data is clearly ongoing, as I've only completed 4 interviews. But we think that future research can test how the pamphlets enhance tobacco treatment engagement after discharge. So we think that by using these, we can track who received them, we can see how their future outcomes have turned out, and see how we can further help them and assist them in their tobacco treatment. Any questions? Yeah.
So one of the things I'm curious about, I know that the pamphlets you're looking at are gendered at this time, which I think is a fine way to kind of begin the process. I was curious if you guys have contemplated any other demographic groupings that could be important. For instance, the LGBTQ community has much higher rates of tobacco and nicotine use. And I think for some LGBTQ folks, having a pamphlet that's salient to them would be more salient than a group divided by male or female.
Yeah.
So is this kind of a starting point? You're going to look towards other demographic groupings?
Oh yeah, this would definitely be a starting point. We definitely want to be inclusive of all, and we want to account for the different groups and how we can help each individual. So if we maybe change, the for pregnancy to for your family for more of a gender inclusive idea, but it's a starting point. So yeah.
How about now? Is that better? Okay, my name is Kaitlyn French-Miller, and I am a research assistant, a graduate research assistant with Dr. Okoli on a Medicaid project. But unlike my colleagues Maddie and Yazan, I'm actually not a College of Nursing student. I am a non-traditional postmaster's graduate student in counseling psychology. So the thing that really got me excited about this project is the historic use of tobacco as a harm reduction in mental health populations, especially in substance use populations, right? So what we have used with clients and what clients have used with themselves for a short-term solution has created a long-term problem. So we know that tobacco use is the leading cause of disease in people living with mental illness in the United States. So 25% of adults in the US have at least one mental illness or substance use disorder. And those adults account for nearly 40% of all cigarettes smoked. Furthermore, tobacco-related deaths are higher in individuals with co-occurring substance use and psychiatric disorders at 46.8% than in the general population at 30.7%. So our goal with this project is to examine the effect of quit and win programs on smoking cessation in community settings. Specifically, we want to assess which components of those contests are most effective in enhancing smoking cessation. Our research questions are, what are the outcomes of quit and win programs on smoking cessation in community settings? And what are the effective components of those programs in addiction or mental health settings? This is an overview of the literature review that we are conducting. We've got our literature search terms there. Our primary intervention that we are looking at are quit and win contests. Quit and win contests are contests conducted by researchers that offer a financial incentive to get their participants to quit smoking. The outcome measures are whether or not they do actually quit smoking, and these studies are only included if they were published before September 2018, and they are excluded if they're published outside of the English language or using interventions other than quit and win contests. Here's a visual aid of our study selection. So we did include many studies that were conducted in Western countries, Canada, the United States, European countries, and Australia. And also there were some international studies, including some that were conducted in developing countries. Only studies published in English, and they had to be peer reviewed. So we initially, our initial results showed 268 studies, and we narrowed it down to 19 to be included in our final review. So here is a visual representation of some of our characteristics of the studies that we have included. As you can see on the left-hand side, approximately half of our studies were published in the United States. And then we had one of each in Hong Kong, the Netherlands, Poland, Iran, Russia, Finland, and Australia. And then there were a couple published in Canada as well. On the right-hand side, we're showing the types of recruitment that were conducted for these studies. Most of them were strictly community media. So that's television advertisements, radio advertisements, newspaper articles, things like that. And then on the right-hand side of that one, it will show some more specific settings where they recruited their participants. So in our review, we noticed that there were two primary study designs. There were cohort studies and there were controlled trials, and they varied in duration in contests. So they were anywhere from 2-week long contests all the way up to almost 2-month-long contests. This table kind of represents the description of our cohort studies with the duration in the middle and the range in quit rates at the end of the contest. So if you can see, the lowest there is 29%, and then it goes all the way up to 76% quit at the end of the contest. The important thing to note here is the lowest quit rate was published in the United States, and the highest quit rate was published in Poland. This next table shows similar descriptions of our controlled trial studies in the review. These studies not only included entry versus non-entry interventions, but also supplemental things such as counseling or pharmacological aids or other support type aids. And what we are seeing is that when you add those extra aids, we are seeing increased quit rates when compared to their control groups. So, our conclusions are that quit and run programs are important public health interventions to enhance community-based smoking cessation. And like I previously mentioned, programs with more intensive components, especially telephone follow-ups and direct counseling, are more likely to enhance smoking cessation than less intensive programs. Unfortunately, to this date, none of these quit and run programs have been conducted specifically in mental health populations. There was one study that did assess depressive symptoms, but no results were followed up on that study. And only a few studies had gender differences, and the results with those were mixed. So the exciting news is that we will actually be launching 2 quit and win contests at 2 community mental health agencies in the area, starting at bluegrass.org and then Participation Station in October. And we really recommend that research continues to assess these in mental health settings. So the best recommendations that we make is that they are conducted for at least a month, and they provide brief intervention for tobacco cessation using the 5 A's. And we also recommend providing information on access to tobacco treatment and referral to tobacco treatment programs. And over here we've got our flyer for a contest that will be starting in October. And I actually don't think there's anything on the slide after that, so I'm just going to leave that for you guys to look at. Does anybody have any questions? Yeah, time.